Good morning. Pleasure to speak with you about a topic of great interest of mine, and try to keep concise. We are doing Q&A at the end, but certainly if there are anything that anyone would like to discuss, happy to do that as we go along also. So just to start with, many patients with kidney cancer will really discuss surgery at some point during their cancer diagnosis. Whether that's up front, whether that's down the line. I think surgery really has a cornerstone role in the management of kidney cancer, and so it's an important topic. And the appropriate surgical option can certainly vary, so it's not all one size fits all, rather. It certainly is a, I guess, nuanced discussion for sure. What I think from a patient perspective has been remarkable is that we've seen dramatic improvements in the number of options, palatable and quality of life focused options for patients in the past 20 years. I think if you looked at kidney cancer circa 2005, we would really have kind of a dearth of the options relative to what we have now. Some of the main advances are coming from what I think my colleagues are going to be speaking with you about, namely radiation treatment options, systemic therapy options, and ablative options. And so I think that certainly doesn't, I think, de-emphasize the role of surgery, and that many patients are still considered for surgery at some point in their treatment course. But I think the real kind of success story is maybe that surgery is not always the only option in 2025. So surgery for kidney cancer, I'm going to focus on 4 broad topics, really, which I think give an introduction to the field. Firstly, I think surgical approach has been one of the big things from a patient-focused viewpoint that has advanced in the past 20 years or so. Secondly, I think the other concept which my colleague Dr. Wang spoke about is the extent of nephrectomy, whether it's a part or all of the kidney, or even in some situations, stuff around the kidney that needs to be assessed surgically. That's certainly another important topic. Next, adjunctive procedures done at the time of surgery can also be a relevant consideration in some patients with locally advanced kidney cancer. And finally, one of the really kind of important concepts as we move into the next decade is how surgery is sequenced or combined with other treatment modalities to provide the best outcome for patients. So when it comes to surgical technique, I think this has really been one of the big advances that we've seen in the past 20 years in making the surgical outcomes, I think, better for patients, allowing them to recover easier, making it a more reasonable course after they undergo surgery. So the conventional surgical approach was open surgery, and this has been around when it comes to the kidney for a couple of centuries. Of course, there have been refinements in open surgery in that time, but fundamentally, I think that open surgery today is very similar to what was done 30, 40 years ago. That's where one has an incision. It could be on the side, could be on the front, and that certainly is very appropriate today for many patients still, but that incision and perhaps some of the other aspects associated with it do create a little bit of a challenge with respect to recovery from a disability standpoint for a short term, as well as pain and hospital stay. One of the real advances, I think, with respect to surgical technique, it started to come into play really about 20 years ago, and maybe over the last 10 years has started to be phased out by robotic surgery. But what's kind of the next advance on top of open surgery is laparoscopic surgery. What's involved with laparoscopic surgery is one uses a camera, and the camera is inserted through a small keyhole, and that allows you to see really well in the abdominal cavity to access the kidney. You then have additional keyhole incisions in addition to the camera incision that you use long instruments to kind of perform what was conventionally done manually with one's hands. And laparoscopic surgery allows you, again, to, a lot of the time, when it comes to removal of the whole kidney, perform what was conventionally done with a much bigger incision. as well. There's thought to be other benefits in that respect. But one of the real challenges with laparoscopic surgery was that the instrumentation was a little rudimentary, and it made performing the same complexity of tasks as open surgery a little bit difficult. And so I think that's really where robotic surgery, which is kind of, I think, the next evolution of laparoscopic surgery has come into play. And I think that in 2025, the majority of kidney surgery is performed with this approach. And the advent of robotic surgery has really, I think, allowed for that shift. Laparoscopic surgery, it did have some limitations with the ability to perform, let's say, the same surgery as the open procedure. But I think for a lot of patients now, we're able to effectively do the same thing robotically. And what does robotic surgery really mean? So in the small, I realize it's a little bit small, but you might be able to appreciate what I'm describing. In the figure here, you can kind of see there are three components. There is the patient where the surgery is actually happening, and then over the patient, there's a robotic set of arms. And these arms, they're not artificially intelligent. They function similar to what conventional laparoscopic surgery did, but they have a lot of advances that allow for 7 degrees of freedom of movement, more precise movements, and this allows basically for a very appropriate reproduction of what happened in an open surgery, but on a much smaller scale. And then over to the left of this little figure in the robotic surgery figure, you can kind of see there's a console where the surgeon actually sits and manipulates the robotic arms. It's almost like a puppet master and a puppet, in that the robot is kind of mimicking what the surgeon is doing on the console. So just to emphasize that, conventional open surgery, as you can see in the left part of this screen, one for a big kidney mass, granted, would have an incision underneath the rib cage. You could similarly do an incision in the midline. And with the robotic procedure, perhaps a very similar procedure occurs on the inside, but with much smaller incisions on the right of the screen here. So just as a blown up figure from what I showed you before, on the left you see the surgeon, and they're working at the console manipulating the robotic arms. And on the right you see the robotic arms at the patient level, and they're separated, by about 10, 12 feet, with an assistant that's at the bedside performing a fundamental part of the surgery, also assisting with kind of manipulation of the robotic arms and certain added tasks. So with this, we see that there's less pain, a shorter hospital stay, less bleeding, a faster recovery, and less wound complications. And I think that with that, really in the past 20 years, we've seen a big shift. What was conventionally an operation that one might be in hospital for 3 to 5 days following, oftentimes one could go home the next day, and in selected settings, even same-day discharge is feasible nowadays. Historically, one would use quite a bit of narcotics following kidney surgery, and the goal in 2025 is that many patients are discharged without the need for narcotics. So just with plain Tylenol and Advil for pain control is often feasible, not always, but often. And I think that from a recovery standpoint, that has been a dramatic advance. And then I think, from a quality of life standpoint, just the reduction in pain, the easier return to day-to-day activity, the easier return to work, and just a shorter time in hospital has really been a patient-centered improvement over the past couple of decades with the robotic approach. Preempting what we just discussed, basically, just to reemphasize that again, a partial nephrectomy is where one removes just a part of the kidney, and a radical nephrectomy is where one removes the entire kidney. There's some subtlety as to what exactly a radical nephrectomy is. In the 1960s, that was defined as removal of all of the fat surrounding the kidney, the adrenal gland, and the lymph nodes. And so a lot of the time in paperwork that a patient might see, it says radical nephrectomy with lymphadenectomy, and if you were to look that up, it includes the adrenal gland and those lymph nodes often. But in the modern setting, we often will use the term radical nephrectomy, but preserve the adrenal glands and not necessarily remove the lymph nodes, just because most of the time there's not a clear indication to do so. So again, just to kind of reemphasize that, most of the time the smaller and peripheral tumor, we really favor a partial nephrectomy just to maximize kidney function and give you more kind of reserve in the future. And for the larger and more centrally invasive tumor, that's really where one would typically need a radical nephrectomy for adequate cancer control. The pros of a partial nephrectomy are really that you will certainly have better kidney function. That may or may not always be relevant, and sometimes you might take a trade-off of that better kidney function for some other benefit of a radical. The analogy I often make is that we have a lot of young, healthy kidney donors in the United States, and they certainly will do very well in the long term with very similar great health outcomes if you donate a kidney relative to if you didn't do that. And so in certain settings, there may not be kind of that role of preserving the kidney if there's another trade-off that's a good benefit that you're getting for that. Let's say better tumor control, or maybe a faster and easier recovery in the patient that might be a really important thing for, like the patient with other medical conditions where easier recovery is really critical. And so the cons of a partial nephrectomy are that if it's a really invasive tumor, you probably can't adequately clear the center of the kidney. Similarly, although for many individuals it's not a really relevant consideration because it's not that different, it is a slightly longer and more complicated procedure. And in somebody where there are other medical considerations, age, other medical issues, and you're really trying to minimize the invasiveness of the procedure, that can sometimes be a setting where maybe removing the whole thing for a slightly shorter and less invasive procedure may be the most appropriate option in the broader goal of getting somebody through a safe operation. And one of the kind of other important things that we'll often, as a kidney cancer surgeon, need to consider is there any role for any adjunctive procedure at the time of removing the kidney, including removal of the adrenal gland, removal of the adjacent lymph nodes, and one of the important unique things about kidney cancer, it has a tendency to invade the veins that drain the kidney. Is there any invasion of the vascular system, namely the vein that drains the kidney or the vena cava, the bigger vein that drains into? And does anything need to be done to address any tumor in those locations? In many patients, fortunately, these are not relevant considerations, but for some people with, let's say, an abnormality or invasion of the adrenal gland, abnormalities of the lymph nodes, or invasion of the vascular system, these are really important kind of nuances surrounding the surgical approach. And then the final topic I was going to speak about, which is really remarkable that this, let's say 10, 15 years ago, was not so important of a topic, but now with the wealth of advances that we have with systemic therapy and radiation therapy, this has become a daily conversation. How should surgery be sequenced with these other treatments? Should surgery be done up front and followed with systemic therapy like immunotherapy? Should surgery follow radiation of another metastatic site? These are kind of becoming a very important part of the conversation. I think a lot of the time, especially if the cancer has not metastasized, the upfront treatment is still surgery, and that may be followed by systemic therapy. It's usually in the metastatic setting where surgery is done after, let's say, a period of systemic therapy, assuming there's been a good response to that. It's a very important conversation in some patients. Just kind of to diagrammatically illustrate that the sequence of surgery now amidst the other treatment options available can be very variable. And so in the last couple of minutes, just to kind of give you some perhaps context for how some of these surgical opinions are formed, I'm going to present a few hypothetical patient cases. So here you can see an axial image of the kidney. You can see a little bump basically coming off the kidney there. This is a healthy 52-year-old lady. She went in, let's say, for appendicitis. this is the typical presentation of somebody with a kidney mass. You go in for another reason, you have a scan, and then you present incidentally. This, I'd say, forms the bulk of our referrals as urologic oncologists, basically to have a shared decision-making with the patient surrounding what to do about this incidentally discovered kidney mass. So a lot of the time now with these small masses, it's felt that surveillance or just keeping an eye on it for a period of time is very appropriate. We think that that not all of them are cancer. Probably at 1.5 centimeters, about 60% of them are cancerous, but that leaves a good proportion that are benign. And a reasonable proportion may not grow, up to a third may not grow, and we believe that the ones that don't grow are not going to metastasize. And so that forms this idea that maybe we can keep an eye on a few of them, wait for them to really declare the need for us to do something about them, and afford patients maybe a less invasive option, which is surveillance, certainly avoiding the kind of risks and downtime associated with surgery. In this case, this mass, let's say it grows from 1.5 to 2.5 centimeters, it's clear that maybe this is growing in a younger, healthy individual. Surveillance is not going to be a long-term strategy. She ultimately has that small segment of the kidney removed, and it's a low-risk kidney cancer with a very favorable prognosis. Meanwhile, you kind of see the other extreme here. On the right of the screen, you can see with the yellow line a large mass of the kidney. This is a CT scan with a patient that's standing in front of us, and so that's actually the left kidney just because it's a mirror image. You could compare that to the right kidney, which is kind of on the opposite end of the screen, and it's a lot smaller. So this patient, there's not a lot of healthy kidney left. They present with symptoms now, as Dr. Wong was illustrating. A lot of patients with a larger tumor will present with symptoms, so this individual might present with blood in the urine. And here, the appropriate option is really to remove the entire kidney or perform a radical nephrectomy.